Welcome to today's Lunch and Learn session, where we explore important topics for multidisciplinary care teams. My name is Sheila, and I'm the Allied Health Engagement Officer at Capital Health Network. We'll be diving into the world of avoidant restrictive food intake disorder, otherwise known as ARFID. We'll be doing this with dietitians from Canberra Health Services, Jelena Puskarica from Community Care Nutrition, and Jodie Paul from the Women, Youth and Children's Services. Now, although there aren't many studies on ARFID, it's been estimated that it is prevalent in 13 people for every 100 Australians. And despite being more common in children, it can actually happen at any stage in life. We'll begin by sharing Jelena and Jodie's recorded discussion. This will cover key facts about this complex eating disorder, how to recognize and diagnose it, and the crucial differences between picky eating and ARFID. Jelena and Jodie will also explore effective treatment options and discuss how medical professionals can support those who are affected, including 8 essential steps that clinicians can take. They'll also share referral pathways for clinicians and provide further information for those who are seeking to learn more. Now, at the end of the presentation, we'll go into a question and answer forum with both dietitians to discuss practical management strategies for practitioners and patients' families. Now, before we begin, let's introduce our guests.
Hello, my name is Jelena and I work with adults with ARFID in the Community Care Nutrition Service within Canberra Health Services.
And my name is Jodie. I work with children and young people with ARFID in the Women, Youth and Children's Nutrition Service with Canberra Health Services.
Hello, Jelena and Jodie. Thanks so much for joining us today and for sharing this audio presentation on ARFID. Now, we're going to start with some key facts. Let's begin.
Here are some key facts about ARFID. ARFID is a mental health disorder, but with significant physical consequences. People with ARFID present with food avoidance, aversion and restriction not related to fear of gaining weight or body image concerns. Eventually, these behaviors lead to failure to meet nutritional and energy needs, which may manifest as weight loss, nutritional deficiencies, dependence on enteral feeding or oral nutrition supplements, and interference with psychosocial functioning. ARFID can affect children, adolescents, and adults, with onset being either acute or chronic. Individuals with ARFID can range from very low to very high weight. ARFID was officially recognized in the 5th edition of Diagnostic and Statistical Manual of Mental Disorders in 2013. This marked a significant shift in acknowledging and diagnosing eating disorders that are not related to body image concerns. However, recognizing and treating ARFID remains challenging due to a lack of research and standardized diagnostic and treatment protocols. Consequently, it can take a long time for patients to receive an accurate diagnosis. Then, even after diagnosis, finding treatment within the community is equally challenging due to scarcity of mental health professionals trained in supporting people with ARFID. Despite the similar prevalence rates of ARFID and anorexia nervosa, which is 0.5% to 5%, and the equally severe consequences of untreated ARFID, clients with ARFID often face greater challenges in obtaining a diagnosis and receiving treatment.
So, how do you recognise ARFID? Clinicians should suspect ARFID when there is food restriction due to one or more of these 3 reasons. Number 1, an apparent lack of interest in eating or of food. This presentation is typical for people who are easily distracted, have high arousal and interoceptive awareness, or low hunger drive. This presentation is commonly seen in people with co-occurring ADHD. It is estimated that up to 26% of people diagnosed with ARFID will have co-occurring ADHD. Number 2, avoidance based on sensory characteristics of food, such as the texture, taste, smell, sight, or temperature of food. Sensory sensitivity to foods may be seen co-occurring with autism. It is estimated that 21% of autistic people experience ARFID in their lifetime. Number 3. Aversion due to fear of adverse consequences like vomiting or choking. This presentation is commonly seen in people with co-occurring anxiety disorders and OCD. Additionally, these behaviours must not be related to weight issues, body image concerns, lack of food availability, or other medical or mental health conditions.
In clinical practice as a dietitian, it is clear that ARFID does not discriminate based on age, gender, ethnicity, or body weight. We see patients ranging from their first year of life to 90 years old with ARFID. There are no two patients with the same ARFID presentation. Some examples from our clinical practice include a young neurodivergent woman in her 30s, maintaining a healthy weight, presents with a severely restricted diet that excludes gluten, fruits, vegetables, and dairy foods. These dietary limitations are rooted in a negative relationship with food, originating from stressful family meal times during childhood and later exacerbated by gradual food restrictions to manage chronic pain. Or another example, a man in his 60s with a complex mental health history who was never really interested in food and eating. After developing a condition associated with a ruptured esophagus, he developed severe ARFID, resulting in significant weight loss and malnutrition and total dependence on tube feeding.
Another example, a 5-year-old child with history of severe anaphylactic allergy reactions and choking incidences, with very restrictive diet with less than 10 foods in their repertoire, only eating puree foods, supplemented by pediatric supplement drinks, and growth sitting below the 3rd percentile. Or another child, a 10-year-old child with co-occurring autism and ADHD. They ate well when starting solids, and over their toddler years they reduced their acceptance of foods, and now they only eat around 8 different foods. They only eat beige, white or brown coloured foods and easily chewable or dissolvable textures. They heavily rely on supplement drinks, and growth is sitting about the 3rd percentile. We see clients with ARFID with varying weights or growth patterns depending on their accepted foods. Some may eat regular high energy dense foods, so they are putting on weight okay, but their variety of foods is quite poor, leading to micronutrient deficiencies. Or their accepted foods are not enough to support them to maintain their weight or growth, but they may be eating from various food groups. Presentations are different from person to person.
How is ARFID diagnosed? As mentioned before, ARFID leads to impairment in physical, nutritional, and psychosocial functioning. Hence, diagnosis requires impairment in at least one of these domains, requiring thorough medical, nutritional, and psychological assessments. A medical professional should include physical assessment and vital signs, blood tests for biochemical markers, eating history, and explore presence of underlying systemic or gastrointestinal disorders which may contribute to the onset of ARFID. Nutritional assessment should determine energy needs, diet adequacy and variety, identify any deficiencies, requirements for oral nutrition supplements or tube feeding, and eating behaviors. A mental health clinician should complete assessment of psychosocial impairment and functioning. If you suspect your patient may have ARFID, look out for the following symptoms. Physical symptoms: delayed growth in children and adolescents, weight loss or difficulty gaining weight in children and adults, height, reduced appetite, fatigue, nutritional deficiency showing as brittle nails, dry hair, hair loss or other symptoms of micronutrient deficiencies.
Psychological symptoms: anxiety and/or distress around food and meal times, difficulty concentrating or learning, and psychosocial impairment. And then behavioural symptoms such as lack of interest in food and/or eating, refusal to eat or a reduction in foods previously eaten, slow eating, stating a fear of choking or vomiting with certain foods, difficulty eating meals with others, going hungry for long periods rather than accepting the foods that are offered, only eating a small number of foods or a limited variety. These foods may be similar in taste, texture, smell, or sight. In severe cases of ARFID, patients may display signs of symptoms of malnutrition, such as fatigue, lethargy, difficulty concentrating, memory deficits, constipation, hypersensitivity to cold, hypothermia, electrolyte abnormalities such as hypokalemia, dry skin, alopecia, bradycardia, orthostatic postural tachycardia, hypotension, and a sunken abdomen. These symptoms are attributed to deficiencies in macronutrients and micronutrients. In addition to significant clinical and nutritional complications, ARFID's selective and restrictive eating patterns have a negative impact on social and emotional development, leading to higher levels of stress and family conflict, and greater likelihood of comorbid neurodevelopmental disorders. The severity of ARFID is associated with higher levels of anxiety, OCD, and trauma-related disorders.
There are screening tools available to clinicians that can help guide the diagnosis. The short ARFID screen has 7 questions. It's quick to complete and can be used by clinicians, individuals, or parents. Other screening tools, like the PADI ARQ, are more comprehensive and may allow clinicians to determine the severity of ARFID presentation, as well as the affected domain, sensory-based avoidance, lack of interest or aversion, but it is time-consuming. Links to these screening tools will be available on the Community Health Pathways ARFID page soon.
So how is ARFID different to picky eating in childhood? Fussy eating or picky eating in young children is a common developmental stage of neophobia. This usually starts around 18 to 24 months of age and generally lessens by 5 or 6 years old. These children are going through a developmental stage of understanding their world and the boundaries around them. They tend to grow out of this stage. There are various definitions out there. Taylor et al. Defines it as an unwillingness to eat familiar foods or to try new foods, as well as having strong food preferences. These children tend to still eat some foods, will eat if they are hungry, and tend to eat better in different environments, such as eating better at childcare compared to at the home, where there may be more pressured eating from parents. Generally, a family-based approach such as the SATA's division of responsibility in feeding alongside responsive feeding will support these children well. The difference with ARFID is it will be a lifelong diagnosis. These children and young people have persistent inadequate nutritional intake and have growth impacts. They generally need nutritional supplements or enteral feeding to support their oral intake. Often they will also have co-occurring anxiety, OCD, or other neurodivergence. ARFID requires diagnosis from a psychologist, psychiatrist, or paediatrician for children in Australia. You can utilise the DSM-5 criteria for ARFID to see if these children may fit this diagnosis.
What is the treatment for ARFID? First and foremost, achieving medical stability before starting treatment will allow proper engagement in treatment. The main goals are weight rehabilitation, correcting nutritional deficiencies, increasing interest in eating, and reducing anxiety around food. The main treatment for adults is a form of psychobehavioral therapy, and for children, depending on their age, they will require parent coaching and/or mental health support and may also require a pediatrician. These treatments can usually be provided as outpatients. GPs play a significant role during treatment in monitoring physical health, such as weight, growth, bloods and vital signs, managing symptoms such as constipation or micronutrient deficiencies, and prescribing medications that may increase appetite or reduce anxiety. ARFID often co-occurs with autism, ADHD, OCD, and anxiety disorders, and medication adjustments may be necessary if medications such as ADHD stimulants for other medical conditions exacerbate ARFID symptoms.
Given the diverse presentations of ARFID, there is no one-size-fits-all approach to treatment. Interventions must be tailored to the primary mechanism of ARFID. Treatment may involve relaxation training, support to change behaviours, gradual exposure to feared foods, parent coaching around feeding styles, reducing pressured eating, and how or what to offer. For instance, if food avoidance stems from a fear of aversive consequences, managing anxiety and using a trauma-based approach with a psychologist would be the most appropriate approach. In cases of low interest in food, education on establishing structure, arousal regulation, and improving attention and focus is crucial. For sensory-based avoidance, dietitians can guide clients through food exposures and confidence-building exercises. Additionally, occupational therapists and speech pathologists can support clients with sensory strategies and the mealtime environment. There are a range of interventions available, such as cognitive behavioural treatment, specifically designed for all three ARFID presentations, called CBT-AR. Behavioural techniques, such as habit acquisition training, responsive feeding therapy, eye movement desensitization and reprocessing, or EMDR. This therapy is used when restrictive eating symptoms are associated with trauma. Additionally, parent-led interventions and group interventions are used to treat ARFID presentations in young people. This highlights the importance of a multidisciplinary team comprising of a GP, dietitian, mental health professional, as well as other allied health or specialist supports as needed.
How can medical professionals support individuals with ARFID? Medical professionals play a crucial role in supporting individuals with ARFID. By recognizing the signs and symptoms of ARFID and establishing an accurate and timely diagnosis, clinicians can ensure that patients receive the comprehensive care they need. Here are some 8 key steps clinicians can take. Step 1. Early recognition and diagnosis is important. Be vigilant in identifying the hallmark symptoms of ARFID. Step 2. Use screening tools. Step 3. Place appropriate referrals to mental health professional, dietitian. When necessary, refer to other health professionals such as speech pathologist, gastroenterologist, and occupational therapist to rule out or manage co-occurring conditions. And step 4. Providing regular communication, maintaining open lines of communication among all team members to coordinate care plans and monitor progress.
Step 5. Provide patient and family education. This may include providing information about ARFID, its symptoms, and the importance of treatment, educating them on the roles of different healthcare professionals included in the care process. Step 6. Set realistic expectations, helping patients and families understand that progress may be very gradual and very slow and will look different for each person. Step 7. Ongoing monitoring and support. Ensure regular follow-ups to monitor the patient's progress, adjust treatment plans as needed, and provide ongoing support. And Step 8. Address co-occurring conditions. Be attentive to conditions such as autism, ADHD, OCD, or anxiety disorders, and adjust treatment plans accordingly. By taking these steps, clinicians can provide comprehensive support to individuals with ARFID, helping them achieve better health outcomes and an improved quality of life.
What are the referral pathways for ARFID in the community? Dietitian referrals. Credentialed eating disorder dietitians or accredited practicing dietitians with ARFID training are best placed to work with ARFID clients. In the ACT, there are both public and private dietitians with training to work with ARFID consumers. Community Care Nutrition and Women, Youth and Children's Nutrition are the only publicly funded dietitian services in the ACT available to clients with ARFID who are not eligible for other eating disorders clinical hub services. The ACD Eating Disorders Clinical Hub will refer people to suitable services, but clients with ARFID-like behaviours need to contact their GP for an assessment.
For mental health referrals, ARFID-trained clinicians across Australia recognise there is a gap in psychologists treating ARFID. At present, in the ACT, we have a limited number of psychologists who treat ARFID. Some mental health clinicians express interest in this area and are looking into undertaking training in ARFID. It is important clinicians work with clients and their support networks to find a suitable mental health professional. Where can you find more information? There is information and health professional training available on certain eating disorder and mental health websites, such as Inside Out, SEED, which is the Victorian Centre of Excellence in Eating Disorders, the Maudsley Centre for Child and Adolescent Eating Disorders, National Eating Disorders Collaboration or NEDC, the Butterfly Foundation, and Responsive Feeding Pro. We hope this information has helped you gain some insight into ARFID and how you can help your clients in this space.
Thank you so much for sharing your knowledge on this very important topic. We have a few questions from our primary care clinicians. How about in terms of going out or going on holidays and maybe for children attending school camps? Are there any particular things that parents should be mindful of or that clinicians can perhaps recommend for families? How does ARFID impact the children in this case?
Yeah, so kind of like preparing to go places with a food allergy, you need to plan ahead. It depends on what the child or the person with ARFID needs. Talking to facilities and facilitators ahead of time regarding foods available, what can be arranged and around their accepted food list, how are these things made, can certain meals be more deconstructed for them to help them pick out the foods that they're comfortable with and still be involved with the meals that others are eating too, or perhaps what things can be texture modified for their needs. Or they might need to consider what foods will they need to bring along themselves. So meals and snacks, supplement drinks, or particular eating accessories. And also considering the meal environment. So do they need a quiet space to eat away from others to help them keep themselves comfortable and more regulated while eating? Are there certain eating accessories or distractions they need to help them feel that comfort as well? And talking to teachers and facilitators about expectations of how much and what they may eat and how this is likely to look different to the other kids or people around them. And this is okay, not to pressure to eat foods they're not comfortable with or pressure to eat at all. Having a note or a card from a parent or from a dietitian saying something along these lines, kept in their lunchbox or on their person so they can hand it over when they're questioned about it, and that helps to communicate their needs more easily. And also if the person has enteral feeds, this may also need to be considered with equipment, the supplements, who is responsible for the feeds and appropriate care, providing a regime to follow. And they might also need notes for, like providers, like flight staff, if they're flying, to take stock of supplements and equipment and things like that too.
What are the treatment costs and options for subsidy?
Yeah, well, Sheila, as you could already hear from our podcast, ARFID is the complex mental health disorder and as such requires multidisciplinary approach. And this can actually increase treatment costs and may pose a financial barrier to accessing ARFID treatment. Well, it's important to know that due to variety in the severity of the presentations, not every patient with ARFID will have the same funding options available. Medical practitioners may be able to use eating disorder treatment and management plans if the patient meets eligibility criteria, allowing for 40 psychological and 20 dietetic treatments within a 12-month period. Recently, the Australian Government Department for Health and Aged Care released the evaluation of the eating disorders medical benefit schedule items known as EDP, Eating Disorder Plan. And some of the key findings are that there is generally low awareness of EDP by health professionals, but also people experiencing eating disorders. And approximately 1 in 5 people experiencing an eating disorder actually accessed EDP. And those who received treatment through EDP reported significantly lower levels of symptom burden after treatment compared with prior treatment, which is great. One of the key recommendations is to simplify and streamline the process for determining eligibility criteria, particularly for people who don't meet the weight status criterion. So watch this space. What we are hoping that this will help with better utilization of EDP and more timely treatment for our clients.
To follow up on that, Jelena, what are the treatment pathways for patients with ARFID at different ages?
When deciding on treatment pathways, actually, general practitioners and patients need to consider their goals, their priorities, and best starting point for treatment. In practical terms, for a young child with ARFID, they may first benefit from GP and dietitian involvement and provision of a parent or carer coaching. Depending on age and presentation, psychological support may be considered next. While for adults with ARFID, they usually require both dietitian and psychological support. As mentioned previously, Community Care Nutrition and the Women, Youth and Children's Service offer publicly funded dietitian support to ARFID clients. So if client is not eligible for eating disorder treatment and management plans, a mental health plan can help subsidize costs for psychologists. Another option for some clients is team care arrangement plans, including a dietitian and mental health professional, which, as you're aware, will provide up to 5 allied health visits each year. You might encourage the patient to use public dietitian services and then use a team care plan to fund psychological services. Again, it might be a good starting point for some patients. And the last one, as ARFID commonly occurs with other conditions such as autism, some ARFID clients may already have NDIS funding in place. However, usual dietitian and psychological services are not covered under NDIS, as ARFID, like other eating disorders, is not considered a disability.
Now, are there studies on the success of treatments or intervention? What is the prognosis if it's not treated?
Yeah, so this is a growing and relatively new area. Overall, high-level quality studies are still needed or are emerging. There's been different studies done. So in 2023, Archibald and Bryant War looked at current evidence for ARFID and the implications on clinical practice and healthcare professionals and future directions. Overall, they found that there was like small-scale studies. A lot of it is around kind of routine clinical capture, robust treatment trials, and around like kind of those clinical pathways. And they didn't really have enough to kind of look at those large-scale studies. There's no kind of those randomized control studies around. But overall, they found that there's support around the MDT treatment approach and looking at making sure there's like psychological treatment in there, medical, dietetic, and other interventions as needed. Beauty and Fuel et al. In 2021 and Sharp et al. In 2017 also found that MDT approach for assessment and treatment for ARFID is crucial too. And they said that looking at that medical and allied health specialists input is important too. And then in 2019, Thomas and Eddie developed and released a new type of treatment, CBT-AR, or Cognitive Behavioural Therapy, ARFID, a 4-stage structured treatment designed for mature adults and mature adolescents and adults, generally over the age of 16. And prior to this age, looking at that family or carer-based approach is generally supported. So with this kind of treatment, they looked at a study, they did a study in 2021 where it evaluated that acceptability, feasibility, and proof of concept for CBT-AR in adults, and then further did another study where they looked at children and adolescents above 10 years of age. And with both these smaller studies, they found that participants had improvement in their ARFID symptoms and severity. Some even reduced so much that they no longer met the criteria for ARFID. They were able to add in new foods, on average 16 to 18 new foods, which is quite significant for this group of people because a lot of the time they might accept less than 20 foods or less than 10 foods. And the underweight subsets also found, they found that they had increases in their BMIs. And then for children, Wong and Roel write about responsive feeding therapy as an effective treatment for ARFID in children. So that's something to look into as well. And then in terms of prognosis, if not treated, so like other eating disorders like anorexia nervosa, if ongoing severe nutritional inadequacies continue and growth or weight are compromised, there can be physical and psychological long-term effects, and at their worst, death. Some may float along in life reasonably okay, but will likely have impacts physically, for example, like fertility issues, libido issues, bone issues, gut issues, fatigue, fainting, headache spells, all those kinds of things. And in children, their growth can be stunted, have delayed puberty and other neurological and neurodevelopmental effects. And then psychologically, ARFID can be very excluding. Humans are innately social beings, and we often use food for celebrations and connection. So if food is difficult to be around, this can be socially excluding. It can impact on their schooling, their work, and their social life. And the increased anxiety around foods has an ongoing mental health effect on these individuals. Overall, increasing risk of mental health conditions like depression, anxiety, OCD, and increased suicidal ideation. So yeah, lots of effects that hopefully we can prevent.
Thank you so much both for your time today. We hope you enjoyed our session on ARFID. You can find our other recordings and clinical education webinars or podcasts on the Capital Health Network YouTube channel. Thanks again for joining us today.